Soz I haven't dusted. I did spritz the room with some Febreze, and that's about the extent of my cleaning of the pod studio.
It definitely looks cleaner. Yeah. The floor.
Yeah, well, it probably helps that it's a paisley carpet, brown paisley, you know, hides all the dust and shit. Anyway, hello, my name is Georgia.
Hey, I'm Olivia.
And Olivia's, she's a 1 out of 10, if that.
Not even that, mate.
She's bleeding, guys. Welcome to womanhood.
Yesterday I shit 6 times in 1 hour.
Period.
Literally. And that was the 4th today.
Yeah, great. How's your week been other than that?
Pretty fucking shit.
Okay. Well,
pretty boring.
Okay.
I hate life.
Period. Same. I have a little update on the guy situation. I eventually got an explanation out of him. Okay. It was like getting blood out of a fucking stone. It was like talking to a 2-year-old. No. But our suspicions were confirmed.
What was suspicions?
He was fucking his ex.
Oh, my God. Have you gone and gotten an STD check?
That is on the books. Wow. That is on the cards, my friend. That is my next task for the day.
Gross.
Why are men like this?
They think they can have anyone they want.
I mean, just stick with one girl. It's not that hard. Or just be honest about it, you know? Like, I don't care if you want to be friends with benefits. In fact, that would suit me perfectly. Yeah. But if you can lie to me, you can fuck right off. I don't need that shit in my life. I want to keep clean. You know what I mean? I don't want no STDs. I don't want no BV. No. I don't want to be sharing a dick with some random.
Yeah.
Soz.
You want your own.
Wrap it up.
Fair enough.
I didn't even ask him if he wrapped it up. I was so fucking over it by then. So
good.
I'm just going to go get a check.
Yeah.
And move on with my life. Find one of the abundant dicks out there to play with. And hopefully it's fun. Anyway, moving on. Guys suck. We've got a really long case today, so we're going to jump straight into it. We are discussing the case of Elaine Bromiley, and this is something that perioperative nurses will be familiar with because it's part of our training in terms of the difficult airway. I'm not really sure if other nurses in different specialties are familiar with this case, but it is a really good lesson about teamwork, about communication, and about hierarchy and how that can affect the patient directly. So before we get into the specifics of the Elaine Bromiley case, I want to start with a little story about a plane crash. Just to switch it up. All right. Okay. So shortly after 5 p.m. on the clear-skied evening of 28th of December 1978, United Airlines Flight 173 began its descent to Portland International Airport. The plane had taken off from New York that morning, and after making a pre-scheduled stop in Denver, it was reaching its final destination with 189 souls on board. As the landing gear was lowered, there was a loud thump and the aircraft lurched slightly to the right. I would be deceased instantly.
Yeah.
The flight crew noticed that one of the green landing gear indicated lights wasn't lit. The captain radioed air traffic control at Portland, telling them, "We've got a gear problem." Portland's control agreed that the plane would orbit the airport while the captain, first officer and second officer worked out what to do. The passengers were told that there would be a delay. The captain crew began to carry out checks. The flight attendants were instructed to check the visual indicators on the wings, which suggested that the landing gear was locked down. Nearly half an hour after the captain told Portland about the landing gear problem, he contacted the United Airlines Maintenance Centre, informing the staff there that he intended to continue the holding pattern for another 15 to 20 minutes. He reported 7,000 pounds of fuel on board, down from 13,000 when he had first spoken to Portland. So they're running out of fuel.
In half an hour, they lost half of their volume, or whatever it was.
Yeah. United's controller sounded mildly concerned. "You estimate that you'll make a landing about 5 minutes past the hour. Is that okay?" The captain's response was very relaxed. "Yeah, that's a good ballpark. I'm not going to hurry the girls," referring to the cabin crew. Essentially, United 173 had 30 minutes of fuel left. The captain and his 2 officers continued to debate the question of whether the landing gear was down. The captain asked his crew how much fuel they would have left after another 15 minutes of flying. The flight engineer responded, "Not enough." 15 minutes is going to really run us low on fuel here. At 18:07, one of the plane's engines lost power. 6 minutes later, the flight engineer reported that both engines had gone. gone and they're still in the sky.
And are there two engines or four?
Oh, but I think only two. The captain, as if waking up to the situation for the first time, said, "They're all going. We can't make Troutdale," which is a small airport on the approach route to Portland. "We can't make anything," said the first officer. At 1813, the first officer sent the plane's final message to air traffic control. "We're going down. We're not going to be able to make the airport."
Wow.
Yeah. This story of United 173 is known to every single airline pilot because it is studied by every trainee. To the great credit of the aviation industry, it became one of the most influential disasters in history. Galvanised by it and a handful of other crashes from the same era, the industry transformed its training and safety practices, instituting a set of principles and procedures known as CRM, which stands for Crew Resource Management. It worked. Although we usually notice only the high-profile exceptions, crashes are at the lowest level they have ever been, and flying is now one of the safest ways you can spend your time. As they are fond of saying in aviation, these days, the most dangerous part of the flight is the journey to the airport. Crew resource management was born of a realisation that in the late 20th century, the most frequent cause of crashes wasn't technical failure. What do you think it was?
Pilot error.
Human error, correct. Its roots go back to the Second World War, when the US Army assigned a psychologist called Alphonse Champanis to investigate a curious phenomenon. B-17 bombers kept crashing on the runway on landing, even though there was no apparent mechanical problems with the planes. Rather than blaming the pilots, Champanis, I can't even say that name.
I see?
Yeah. Champanis?
Japanese?
Champanis. You may not even say S. I don't know.
Yeah, Japanese.
Anyway, this guy pointed to the instrument panel. The lever to control the landing gear and the lever that operated the flaps were next to each other. Pilots, weary after long flights, were confusing the two, retracting the wheels and causing the crash.
This reminds me of, do you know that show, Air Crash Investigations?
Yeah.
Oh my God.
I never watch it because I'm terrified.
No, fair enough. I was obsessed with that show as a kid, and as were my parents. And every time it was on, we would watch it. And, you know, of course, a few years later, I ended up like going on multiple planes overseas and stuff, and I've psyched myself out thinking about all that. But I remember very specifically a lot of the episodes where most of the time the crash is not caused by anything to do with the plane or the engineers who maintain the plane. But that is like the second most common cause is like worn parts and stuff that's not maintained properly. But the first most common cause is pilot misconstrues something, miscommunicates with their first officer or whoever it is that they have assisting them with flying the plane, and like just miscommunication with cabin crew, and then not reading the manual and stuff properly, and then communicating the manual.
Terrifying.
Like, well, in an emergency situation, every plane has a manual that tells them exactly what they need to do.
Much like healthcare.
Even though they need to know it.
Algorithms, they
need to refer to that book.
Yeah, you got to revise it,
Exactly. But
situation.
And it's just amazing how the biggest thing I think is, fatigue.
Yeah. Oh,
is
absolutely.
What does it. 12-hour flights, days and days on end, flying planes. You don't really get much of a break, and if you do, it's shift work type stuff, right? So there's no routine and anything, and then people are absolutely shocked when something bad happens.
Not shocked.
Yeah, right.
Yeah.
It's not
It's terrifying
shocking,
because you are just putting your lives in people's hands.
Yeah.
And
one
even
person, literally.
Yeah,
or two people.
Two. There's always got to be a backup pilot.
Yeah.
But you know, that being said, it's the same as healthcare, and that's why I'm telling you this story as a precursor to what I'm going to tell you soon.
Human error relates to all of these things. You can apply it to everything, really.
Period.
Yeah.
So Champini, I don't know.
Champini, she's saying
anyway,
now.
This psychologist suggested attaching a wheel to the handle of the landing lever and a triangle to the flaps lever, making each easily distinguishable by touch alone. Problem solved. There was no more crashes. He recognised that human beings' propensity to make mistakes when they are tired is much harder to fix than the design of levers. His deeper insight was that people have limits, and many of their mistakes are predictable effects of those limits. That is why the people who created CRM defined its aim as the reduction of human error rather than pilot error. Rather than trying to hire or train perfect pilots, it is better to design systems that minimise or mitigate inevitable human mistakes.
Yeah, and that's what a lot of what comes out of those unfortunate crashes that do happen on that show as well is there are so many safety mechanisms that have now been implemented over the last 20, 30 plus years in planes because of all of these. And I know a lot of people have lost their lives, of course, but there has been massive improvements and changes in the way things are done, I believe, now.
Which is what you would hope.
Yes, of course, you need to learn from your mistakes, and that will tie into the Elaine Bromiley case.
Totally.
The things that were changed afterwards.
Yep. In the 1990s, a cognitive psychologist called James Reason, a much easier name to say, turned this principle into a theory of how accidents happen in large organisations. When a space shuttle crashes or an oil tanker leaks, our instinct is to look for a single root cause. This often leads us to the operator, the person who triggered the disaster by pulling the wrong lever or entering the wrong line of code. But the operator is at the end of a long chain of decisions, some of them taken that day, some taken long in the past, all contributing to the accident. Achievements and accidents alike are a team effort. James Reason proposed a Swiss cheese model. That is who created it. Accidents happen when a chain of factors occur in unpredictable ways, like the holes in a block of cheese lining up. James Reason's underlying message was that because human beings are fallible and will always make operational mistakes, it is the responsibility of managers to ensure that those mistakes are anticipated, planned for, and learned from. Without seeking to do away altogether with the notion of culpability, he shifted the emphasis from the flaws of individuals to flaws in organisation, from the person to the environment, and from blame to learning. The science of human factors now permeates the aviation industry. It includes a sophisticated understanding of the kinds of mistakes that even experts make under stress. So when Martin Bromiley read the Harmer report following the untimely death of his wife Elaine, this incomprehensible event suddenly made sense to him. He thought, this is a classic human factors stuff. Fixation error, time perception, and hierarchy. So on to Elaine's story. Early on the morning of 29th of March 2005, Martin Bromiley kissed his wife goodbye, along with 2 children, Victoria 6 and Adam 5. He waved as she was wheeled into the operating theatre, and she waved back. Over Christmas, Elaine had suffered a swelling of her face, connected to sinus problems that had troubled her for years. She was advised by a consultant that the only way to deal with the problem once and for all was to undergo a minor operation to straighten the inside of her nose. Martin Bromiley was a pilot and knew of colleagues who had undergone the operation. The sinus of pilots take a beating from sharp changes in air pressure. So he didn't feel overly concerned that morning as he drove Victoria and Adam back to the family home in a peaceful Buckinghamshire village. At about 11 that same morning, he received a call from the ear, nose and throat consultant. Quote, Elaine isn't waking up properly from anaesthetic. Can you come back in? At the hospital, Martin was met by the consultant, who explained that there had been a problem keeping Elaine's airway open after she had been anaesthetised, and her oxygen levels had fallen to dangerously low levels. A decision had been taken to move her to the intensive care unit. Grasping for medical knowledge from half-remembered episodes of casualty, Martin asked if the doctors had attempted a tracheotomy, a cut to the throat to allow air in. They explained that the safer option had been to let her wake up naturally. He made his way to the intensive care unit. When he got there, the first person to approach him was the consultant anaesthetist who, without saying anything, gave him a hug. Bromiley found himself trying to console him. I said, I know these things happen. Poor guy. He took a seat and waited for the news. After 10 minutes, 2 doctors emerged and took seats opposite him. In sombre tones, they told Martin that Elaine had been without oxygen for a long period of time and, as a consequence, had suffered severe brain damage. He could hardly process what they were saying. I just thought, fuck, what? How? I was stunned. My whole world changed. An hour later, Martin was allowed to see his wife. She didn't look any different, he said, but she was different. After finally settling her oxygen levels, the doctors had put her in a coma to prevent her brain from swelling to the point where it crushed itself against the top of her spine. Brain herniation, that's called. It soon became apparent that it was a coma from which she would never recover. Days later, after a series of discussions with the doctors, he consented to having her life support switched off. The doctors were surprised at the strength of her heart, which continued to beat for another week on.
Wow, I didn't know that.
Until the 11th of April 2005 when Elaine finally died. Isn't that crazy?
Yeah.
Very, very fucking sad. Most of you will already know that Olivia and I are anaesthetic nurses, which means we directly work with anaesthetists in the operating room to anaesthetise watch over and wake up the patient and then recover manage their airways, manage the drugs, and just be the anaesthetist's extra eyesies and hands, basically, is what I like to say. We take direction from the anaesthetists, but we also operate our own clinical judgment and critical thinking in situations where the patient has difficulties with their airway, we have difficulties with their airway, or there's something that happens surgically that we have to manage.
Especially in PACU, something's gone wrong with the surgical site.
Yep. Or in their recovery, exactly. Yeah. So we work as teams. We work alongside 2 other nurses who work on the surgical side. There's a surgeon, there's often assistants, and then there's the anaesthetic team. In public hospitals, they have more staff around because there's trainees, and in private, there's typically less.
Yeah.
So this is going to be particularly interesting to anyone who is training as an anaesthetic nurse or an anaesthetist, I suppose. Not that I'd expect them to be listening, but they might be. Hi.
Hopefully some of them do.
I hope so, yeah.
And they get a different perspective on healthcare in general.
Yeah. I've read the Harmer's report, which is the incident report about this, and so I'm going to be reading directly off there. Okay. So let's get into it. The specifics. Mrs Elaine Bromiley was a 37-year-old mother when she presented at the clinic on March 29th, 2005 for her surgery to her nose. On the day of the surgery, she arrived at the hospital at about 7:30. She had been assessed prior to admission on 21st of March 2005. So anaesthetists typically call them and do an assessment. At the time, the preoperative assessment questionnaire highlighted only one matter of note, that she had a congenitally fused vertebrae in her neck. The only other matter of note was that she was using a nasal spray twice a day to help the nasal symptoms, which is what Olivia is currently doing.
Yeah, currently, and also since I've been like 8 years old, so...
Yeah, she just gets around with this I think I've got one of your nasal sprays in my car, actually.
I've quit twice in my life.
Yeah.
And the longest I've quit it for was 2 years, and then I got really sick again and I started using it again, and that was 2 years ago, and then I haven't stopped since then.
She had previous anaesthetics for a repair of a hernia and an appendectomy at age 7, and had 2 caesarean sections 4.5 years ago. There is no mention of the type of anaesthetic used, but given modern practice, one would assume that she had a spinal for the caesareans.
Yes, I wouldn't have thought she'd have any sort of airway.
Yeah, but she would have had airway, airway placed for the hernia and the appendectomy, but she was 7.
Oh, that's so entirely different.
Younger.
Anatomy is totally different, guys.
Mm-hmm. Yeah. Given the lack of any significant cardiovascular or respiratory symptoms and the relatively minor nature of the intended surgery, the only investigation that was requested was a full blood count to check the level of hemoglobin, because the nose tends to bleed. This level of investigation was appropriate in this case, and I would agree. Mrs Bromiley was admitted under the care of Mr E, who was the ENT surgeon. So all of the healthcare practitioners in this are just under initials, just for their own privacy, who clearly saw her when she was admitted and completed the operation consent form with her. The scheduled surgery was endoscopic sinus surgery and a septoplasty. Okay, so the consultant ENT surgeon, Mr E, was an experienced surgeon who has worked for many years both in the NHS and the independent sector. The consultant anaesthetist was Dr. A and was an established consultant working in both the NHS and the independent sector. His NHS colleagues comment that he is a very diligent and caring doctor who practices careful anaesthesia. Dr. B was a consultant anaesthetist and was working in the adjoining operating theatre on the morning of the incident and became involved in the management of Mrs Bromiley as he had additional skills pertaining to the difficult airway. He again is a respected consultant working in both the NHS and independent sectors. There is nothing to suggest that any of the medical staff involved were not experienced nor up to date with their continuing professional development. So, immediate preoperative anaesthetic management of Mrs Bromiley.
Let's just say this surgeon and anaesthetist have probably done this procedure
bajillion times.
So many fucking times. My experience working with ENT surgeons, they are the boss at the fucking airway.
Oh, yeah.
They just slip the airway in and out as they need while they're operating. Yeah. And it's like they get it perfect every single time. So I am sure that these people went in thinking this was going to be nothing other than another routine operation, right?
Yes, this is what the documentary is called, routine operation.
Just another routine operation, because that's what they all are to us, though, every single time.
So let's go into the immediate preoperative and anaesthetic anaesthetic management of Mrs Bromiley.
Yeah.
It's clear from the clinical notes that Mrs Bromiley was seen by Dr A prior to the operation. The anaesthetic chart notes said, previous GAs okay. Cervical vertebrae fused congenitally. Generally well. Medication, nasal drops. Allergies, nil known.
So the main risk there is what? Lack of neck
flexion. Yeah.
Flexion.
Yep.
With the fused
and extension.
vertebrae.
Yep. Non-smoker, occasional alcohol, no dental problems, fasted. In addition, there is a separate assessment of the airway. Mouth opening okay. Melon patty wasn't mentioned.
What?
It just says melon patty.
Right.
Not sure why.
So you know
They
how
find out later.
They don't like to fill it out, some of those
They
things.
find out later.
Okay.
Neck movements slightly restricted.
Melon patty minus 100.
The proposed plan was for a general anaesthetic for the procedure. In addition, analgesia was discussed and the use of rectally administered diclofenac, a non-steroidal anti-inflammatory painkiller, was covered.
That's Voltaren.
Yeah, it
If
is.
anyone
You're right.
doesn't know.
Yeah. The blood pressure and hemoglobin levels were within the normal range for a woman of Mrs Bromiley's age. There would not appear to be anything of particular note in the preoperative anaesthetic assessment and management.
So she's the perfect patient
Yeah,
on
so
paper,
far.
pretty much, yeah?
Yep, except for the neck thing.
Yes.
The existence of a neck problem was identified and its possible impact predicted by airway assessment. So they're onto it. Whilst there was a slight restriction in neck movement, there was nothing to suggest that Mrs Bromiley would pose a particular problem with regard to airway management during anaesthesia. This was the impression Dr A had, and in his comments he enlarges on the preoperative findings. Quote, with regards to the neck problems, there appears to be little restriction in the flexion extension, which is head forward and head backwards, with only a little limitation in rotation. Mouth opening was normal, as was the thyromental distance. The Melon-Patty score, a measure of predicted difficulty in tracheal intubation, was grade 2 at assessment. Sorry, there we go. It was grade 2. Dr. A felt that these findings did not constitute a major difficult airway potential, a view with which I would agree at this point. So he looked at her, got her to open her mouth, looked into the back of her throat and said, okay, that's a melon patty too. But we find out later it wasn't. Because there's only so much you can tell from a pre-op assessment, guys. That is just the reality of airway management. The proposed anaesthetic technique, as outlined by Dr. A's comments, was to avoid tracheal intubation and maintain the airway with a laryngeal mask. Anaesthesia was to be maintained with isoflurane, a potent inhaled anaesthetic agent carried in a mixture of nitrous oxide and oxygen. This is routine. Analgesia would be provided with an infusion of remifentanil, a very potent short-acting analgesic. This was a reasonable proposed technique. So the anaesthetic management. Mrs. Bromiley was checked in for surgery by Mrs. K, senior operating department practitioner and main assistant to Dr. A. So that would be us in Australia, but I don't even know if she's a nurse. It just says senior practitioner. I don't, because in America they don't use anaesthetic nurses. They use anaesthetic techs, and they're not even registered nurses. They're just trained in anaesthetics, and that's it.
Sounds like some nurse in charge type person, like running the floor.
Yep.
Maybe.
Probably. She noted that there was a history of fused cervical vertebrae and commented upon it. She was assured by Mrs. Bromiley that it had not been a problem. On arrival in the anaesthetic room at about 8:30, routine monitoring was set up. This was a blood pressure cuff to ensure blood pressure regularly during the operation, an ECG, monitor of the heart electrical activity, and a pulse oximeter, monitor of the oxygen levels in the blood for anyone who is not healthcare. These are routine monitors that are attached to all patients having a general anaesthetic. This level of monitoring is as recommended in the AAGBI guidelines, which I assume is the guidelines that go off in the NHS. An intravenous cannula was placed in Mrs. Bromiley's left hand prior to administration of the anaesthetic. Prior to the induction of anaesthesia, the pulse rate was 81 beats per minute with an oxygen saturation of 98. These are both normal. There is no record of the blood pressure at that time. Suspect. You usually get a pre-op blood pressure, guys. You have to have a baseline. Yeah. There is no record of a period of pre-oxygenation prior to the induction of anaesthesia. Also quite suspicious.
Yeah, that's very interesting.
You don't do that. You always pre-oxygenate the patient.
Except when you get the anaesthetist that's like,
fuck that. Yeah, exactly. But this is why we do it. You'll find out. It's a procedure that allows a store of oxygen to be in the lungs should problems arise.
There's always a reason.
It's always smart to pre-oxygenate, right? Take the time.
I mean, I believe pre-oxygenation can give you up to like an extra 5 to 7 minutes or something like that.
Exactly.
If your patient crashes and you can't ventilate them, you have reserve.
Yeah,
that's
exactly. That's the
whole
point. Yeah. So we've constructed a timescale from the report during the anaesthetic, but there is no information recorded on the anaesthetic chart because shit hits the fan and you don't document. The following is based on the other clinical notes and comments for staff. So, At 8:35, anaesthesia was induced with an infusion of remifentanil, 0.3 micrograms per kilo per minute, and an intravenous injection of propofol, 200 milligrams, a very rapidly acting anaesthetic. That is what we use for induction. The proposed airway management was with a flexible laryngeal mask airway, but it was not possible to insert this immediately due to inability to open the mouth as a consequence of increased tone in the jaw muscles. Very common occurrence.
This is a side effect of remifentanil and stuff as well, and now fentanyl can cause like chest wall rigidity depending on how much you give, so it can actually affect ventilation of the patient.
And it just often happens at induction when you don't give enough propofol as well.
Yeah.
This can sometimes occur when anaesthesia is light and is usually overcome by giving an additional dose of anaesthetic. In this case, Dr. A gave another 50 milligrams of propofol and had a second attempt. He tried 2 sizes of a laryngeal mask airways once the mouth opening was happening, sizes 3 and 4, but was unable to insert either. So at 8:37, which is 2 minutes later, Mrs. Bromiley's oxygenation began to deteriorate and she looked cyanosed, which is blue.
Is that because she's not being ventilated anymore and they're just fucking around trying to get this thing in?
Yeah. So they've tried to put a 3 in and they've tried to put a 4 in, and by the time they've done those 2 things, she's start to go cyanosed. And this is something that happens every time. Like,
but how was the bag mask?
They go,
ventilation.
Yeah.
Was it? Did they do any of that?
There's no mention of it.
Oh my god! Well, there you fucking go.
They just slammed in some fucking.
And we see classic.
That, don't we?
Slam
dunk, they call it.
No, I'm not going to bag. I'm just going to.
Because I'm going to oxygenate them with an LMA. That's what I'm going to do. It's going to be great. And it's just like, but you need to check if they can be bag valve masked first.
Bag valve mask.
Bag mask valve. B&V, isn't it? That's what it's called, B&V.
Yeah. But like,
you need to check if they're able to be bagged first, so that you can revert back to something. Yeah. Right.
AKA not the anaesthetic machine. So if you need to have a external sort of point of ventilation, you need to know you can bag mask them, because what if your anaesthetic machine fails as well, and correct. You can't get an airway in as well.
That's it.
You have to be able to bag mask a patient. Yeah. You must know.
It's an easy one.
I fucking hate when they don't do it.
So do I.
Especially if the patient is a big man with a lovely, gorgeous, long, curly beard.
Yeah, fucking period. So at 8:37, Mrs. Bromiley's oxygenation began to deteriorate. She went blue. Her oxygen sats at this time was 75%. Anything less than 90 is significantly low, and her heart rate was raised. At 8:39, the oxygen sats continued to deteriorate to a very low level, 40%.
So how many minutes past induction is this now?
Like 4?
4,
yeah.
Okay.
Over the next minute or so. Attempts to ventilate the lungs with 100% oxygen using a face mask and oral airway proved extremely difficult. So they reverted back to a Gadell and a face mask, which is what they should have done at the start.
They've probably caused some airway trauma as well now, fucking around. Things are going to swell up a little bit.
Yep, they definitely did.
Oh, we got to read that. Oh, the Gadell's not working very well. Oh, I wonder why.
Between 8:41 and 8:43, it was still proving near impossible to ventilate the lungs, and the oxygen saturation remained perilously low, 40%. It might have been lower, but I think the monitor had a lower limit of 40%. Like, I don't think I've ever seen it go below 40.
Really?
Have you?
Oh, 23 is the lowest I've ever seen, and then he died.
So ours go lower then.
They should. They should go down to like 20.
Okay.
Yeah.
In combination to the extremely low oxygen saturation, the heart rate had started to decline to 69 beats per minute, with a downward trend continuing to the low 40s.
So it increased originally. Yeah. It will increase originally to try to compensate for the lack of oxygenation, and now it's already tried to compensate. It can't compensate anymore. The heart is now going to start failing as well.
Yeah, it's indicative of a lack of oxygen to the heart. Like your
heart
won't beat.
It's gotten to that point.
Yeah.
Yeah.
Dr. A decided to attempt tracheal intubation at this point to overcome the problems with the airway. He gave 0.6 milligrams intravenously of atropine, a drug to counter the slow heart rate, suxamethonium 100 milligrams, a fast-acting paralytic drug to allow the insertion of the tracheal tube fast. At this time, Dr. A was joined by Dr. B, who had been about to start an operating list in the adjoining theatre. So people are twigging on the shit's going south by now. Like, if you've got a SATs of 40%, people start to take notice.
You can hear things happening as well.
Oh, for sure.
Yeah, you see it,
you have to have some situational awareness in the operating room, for sure.
Sense it.
People stop. At 8:45, on insertion of the laryngoscope to allow insertion of the tracheal tube, It was impossible to see any of the laryngeal anatomy. This view at laryngoscopy is classified a grade 4. A grade 4 airway in the context of airway assessment using direct laryngoscopy signifies that neither the glottis nor the epiglottis can be visualised. This indicates a difficult or failed view during direct laryngoscopy and means that tracheal intubation is likely to be very difficult, if not impossible.
Did they use a video laryngoscope at any point?
You'll find out.
Okay. I'm wondering
it's like
why
Olivia's
he went...
brain is like ticking over, like, what do we do next? And that's what we do.
Why he's gone straight for
that's what they do. They go direct.
laryngoscope.
Yeah.
No, not always. In that situation, if the patient's SATs are like that,
Yeah,
they're going to be like, they're using the glide scope. There is no question about it. Unless
that's so true.
they are just like, they know that this patient can be intubated.
Yeah, but they don't, because there's no mention of airway issues in the previous anaesthetic charts.
Yeah.
The oxygen saturation remained very low, though the heart rate increased to 64 beats per minute now, probably as a result of the atropine. That's not very much.
Yeah, so actually, also if he's given some sort of heart medication like that and there's not enough oxygen to go around, what is he actually...
work.
Yeah, what is he doing? He's increasing the heart and the work of the heart when there's still zero oxygen for it to work.
It's just not going to work. By about this time, other staff had been summoned to the anaesthetic room to provide any necessary assistance. Mr. E also entered the anaesthetic room at about this time. So they must induce in the anaesthetic bay here. And
they
that's
do
not,
some
that
places.
happens. That happens at Peter Mac.
Yeah.
Yeah, they have a ventilator in there and then they go through. Between attempts at laryngoscopy, ventilation still proved extremely difficult despite the use of four-handed attempts. So someone holding the mask and someone giving a jaw thrust, right? So zero ability to bag mask this person.
Yeah.
The situation now was what we call in the OR, can't intubate, can't ventilate, and is a recognised emergency in anaesthetic practice for which guidelines are available. So between 8:47 and 8:50, further attempts at laryngoscopy and intubation were made using different laryngoscopes by both Dr. A and Dr. B, but to no avail as the larynx could not be seen. Dr. B attempted visualisation with a fibre optic flexible scope, but was unable to see due to the presence of blood obscuring the view through the scope.
She's all fucking
airway
traumatised in there.
Yep.
Don't just stop trying at that point.
Yeah.
I've been in that situation before where they keep trying and keep trying and keep trying.
You're like, try something new. The oxygen sats remained very low at 40% and the heart rate again was beginning to slow. By this time, staff had ensured that all possibly needed equipment, including a tracheostomy set, was available in the anaesthetic room or in the close vicinity. So nurses are like hovering and going in and out and getting things and suggesting things, and they're being completely ignored. Between 8:51 and 8:55, Mr. E, the surgeon, attempted intubation with a standard anaesthetic laryngoscope. Because why?
That's a shame. They were all ignored, like as in told, no, we're not going to do that?
No, they just did not respond to them at all.
Well, you know, it's interesting.
They've got tunnel vision.
In codes, though, I don't think I've ever actually had my suggestion be... I've always had my suggestions taken on board. I don't know, there's one time no one was thinking of a central line and I'm like, how about we put a central line in? And then all the anaesthetists just go, that's a great idea. Can you go get the shit? Of course I can.
Yeah, there was one time where we were having trouble getting an airway and the sats were dropping. I said, have you checked that it's not in the esophagus? And he went, and
Let's
then he
check.
pulled it back.
Let's check.
Yeah. And it was in the esophagus.
Simple.
And there was another time where it was just in one lung. And I was like, he's like, oh, we're oxygenating, but we're not oxygenating. I was like, do you think it's too far down?
You want to listen to the chest?
Yeah. And then he like pulled it out and was like, yeah, it was. Good call. Like, listen to your nurses.
There are so many times that this
and it's
has
because
happened to us.
you need
and they're
multiple
like,
brains.
Thanks.
You need multiple points of view because you do get tunnel vision.
And it doesn't mean that they are incompetent or wrong or not a good doctor. It just means they are so focused on saving this person
on one point
or
of view.
doing something.
And stress clouds your thinking.
Human error.
For sure.
You lose focus of other things. And it's just good to have other eyes that are maybe not so attached to the situation that's happening, right?
Correct.
You walk in and you have a more objective view of it.
Yeah, correct.
And then you can see exactly what has happened, what hasn't happened, and what may need to happen.
Exactly. So between 8:51 and 8:55, the surgeon attempted intubation with a direct laryngoscope. Oh my God. He was able to see the very end of the epiglottis, top part of the larynx, and attempted to pass a bougie into the larynx over which a tracheal tube could be railroaded. He was unsuccessful, unfortunately. The oxygen sats remained at 40%. There was a recordable blood pressure at this point.
That's good.
I know. And the heart rate was now high. at 140 beats per minute, which is interesting. Might just be the fact that they're reefing on like the laryngoscope and really like triggering that sympathetic response. Yeah.
But also, are they doing CPR at this point? Are there compressions happening? Because if there are compressions happening, then maybe
the heart rate is still happening. So,
well, I'm just thinking like maybe they put something in and they're doing compressions, but like it all hit at once maybe, and then our heart rate went up to 140.
Listen, they're so focused on the airway. That is what they are, so focused on the airway, and they're not looking at anything else. That is the situation.
I wonder what made her heart rate go up. Like, what is the physiology there? I'm curious.
Well, I just think it's stimulation. Yeah.
Okay. Yeah, could be, for sure.
Insertion of an intubating laryngeal mask allowed some ventilation. So they went back to the LMA. Though it still remained difficult to ventilate the lungs because, you know, probably the blood.
Yes.
At the time of insertion of the intubating laryngeal mask, oxygen sats was still at 40% and the pulse rate was high at 133. The insertion of the intubating laryngeal mask improved matters, and at 9 o'clock the oxygen sats rose to 90% with a raised blood pressure and heart rate. At this time, a dose of steroids, which was dexamethasone 8 milligrams, was given, presumably to help protect the brain from hypoxic damage. Between 9:03 and 9:09, attempts were made to insert an endotracheal tube again through the intubating laryngeal mask. Initially, the attempt was undertaken blindly as the device is intended to work. Like, there are LMAs that allow a endotracheal tube to pass through, and then you can take the LMA out. It's kind of like a bougie sort of situation, but different. Initially, the attempt was undertaken blindly and then using a fibre optic flexiscope. The latter attempt by Mr. E failed as he was unable to pass the scope through the end of the laryngeal mask, a recognised problem with this device. During these attempts, the oxygen saturation was unstable, dipping down to 49 on occasion, and at no time did it exceed 90%. So this is like 30 minutes worth of 40% oxygen at this point, guys. At 9:10, in view of the problems encountered, it was decided to abandon the procedure and allow Mrs. Bromiley to wake up.
About fucking time.
Oh my God.
Jesus.
Between 9:13 and 9:29, the remifentanil infusion was stopped and spontaneous breathing began. Up till that time, the lungs had been ventilated by squeezing the bag on the anaesthetic machine. The laryngeal mask was removed.
So they're doing manually the whole time?
Yeah. The laryngeal mask was removed and an oral airway inserted. Oxygen saturations gradually improved, reaching near normal levels of 95%. Throughout this time, the blood pressure was markedly elevated, as high as 192 over 126.
Sounds like so that at that point you wonder if the brainstem is affected
The
brain,
Yeah. And the heart rate was very high, up to 152 beats per minute.
No.
Once Dr. A was happy that Mrs. Bromiley was breathing satisfactorily with the oral airway in place, she was transferred to the recovery room.
Why?
I know.
She should have gone straight to ICU. What the fuck are you doing there?
Yeah. At this time, Dr. A thought that Mrs. Bromiley was showing signs of recovery and was breathing with a normal pattern, so that's why. In total, during the attempts of intubation, Mrs. Bromiley's oxygen saturation was extremely low for some 20 minutes. Yeah, and then it went up and down.
Wow.
So the immediate, that's fucked, man. So the post-op care. Mrs. Bromiley was admitted to the recovery room at 9:30. Mm-hmm. Her obs on admission were a pulse rate of 120, a respiratory rate of 20, blood pressure 84 over 33, temp of 35.1, and an oxygen sats of 95%. Mm-hmm. The recovery staff were aware of the problems that had occurred and were informed by Dr. A that he would expect Mrs. Bromiley to recover consciously slowly, which I don't understand how he came to that conclusion. Because as we know from the Max Mackenzie case, where, you know, I covered this on TikTok and I intend to cover this on this podcast too. Tragic case, 14-year-old boy, anaphylaxis, went to Box Hill Hospital. They failed to be able to get an airway in. There was a lot of delay on front of neck access, and it resorted to his father, Dr. Mackenzie, who was an emergency physician, to actually do the front of neck access on his own child. Yeah. Anyway, after that, he died because of the delay in oxygenation, and Dr. Mackenzie came up with an algorithm called the AMAX4, which is essentially how to manage an airway in a specific circumstance relating to anaphylaxis and asthma. And in that algorithm, he states specifically that you can only go 4 minutes max at 40% oxygenation before brain injury starts to occur. So
is that in a pediatric patient?
Anyone with anyone. Yeah, it's baffling to assume that someone would wake up after half an hour at 40% oxygen. Like, that just makes no sense. Anyway, expected her to gain consciousness slowly. After a short while, with Mrs. Bromiley, Dr. A left the recovery room to continue the operating list. It's clear from the statements of the recovery room staff, who are referred to as nurses D and S, and subsequent interviews that they were far from happy with Mrs. Bromiley's condition. Even nearly 1 hour after admission, there was no signs of recovery of consciousness, and whilst Mrs. Bromiley was breathing, the pattern was erratic.
And why wasn't she in ICU yet? Still?
Because they expected her to wake up, which is so not good.
But she has airway trauma.
That's
she
crazy.
should be in ICU anyway.
Yeah. She has a blood pressure of 80.
Yeah. And her heart rate's doing shit.
She had no fucking airway for half an hour. What are you talking about? Anyway, the blood pressure was equally erratic, with swings from very high to very low. That's just indicative of brain trauma. Yeah.
There's no homeostasis.
Yeah. Yep. The oxygen sats equally showed swings. Most concerning to the recovery room staff were periodic episodes of movement that looked like fits. These were associated with further swings in measured parameters such as signs of cerebral irritation and require prompt appropriate action like going to ICU. On several occasions, the recovery staff asked Dr. A to come to see Mrs. Bromiley, but that was not always possible as he had already started to anaesthetise the next patient on the operating list, a common occurrence. On occasion, Dr. B came to see the patient, but he, quite legitimately, had a duty of care to his own patients. The exact times when requests were made of Dr. A are not recorded, but it is clear that the recovery room staff felt that Dr. A should have been readily available to deal with any problems. I agree. Concerns increased, and eventually it was decided that Mrs. Bromiley needed to be transferred to the intensive care unit, as both Dr. A and Dr. B were unavailable. Another anaesthetist attended to supervise the transfer. This took place at around 11, and Mrs. Bromiley was transferred to NHS hospital. At this time, she was in an unstable condition, though was still breathing on her own. The exact sequence of events is not entirely clear, as there is no record of measurements made. It is normal practice to have written records of cardiovascular variables, and I can only assume that if such exists, that it had been mislaid because of the circumstances. So the subsequent management. On admission to the ICU at a NHS hospital, they don't mention any of the clinics or hospitals, it was clear that Mrs. Bromiley had suffered marked brain damage and urgently required ventilation. Again, there were problems with placing a tracheal tube. Finally, it was possible to insert one through her nose and into her trachea.
Why are they still going for that?
Well, this is at a different hospital in ICU.
Okay.
She needs to be tubed.
But why not go for a trachea if she's got so much airway trauma already?
I'm not sure. Mrs. Bromiley's condition did not improve, and her clinical course led to her ultimate death. There was clear evidence of severe cerebral damage through her time on the intensive care unit. So, how could this have happened? When he surfaced from the shock, that was the question to which Martin wanted an answer, her husband. At first, he accepted the word of the NT consultant, who told him that the doctors had made all the right decisions, the audacity, but had simply come up against an emergency for which nobody could have planned. Incorrect.
What?
The exceptional difficulty of getting a tube down Elaine's airway. Mate,
you should always have
that
a
is...
plan for that, and you should always be ready for that.
You should always plan to fail too. You should always make sure that you have a backup plan for your airway plan.
Always ask, and what would you like for a backup airway?
Correct.
So fucking easy to ask that question.
People just, people will be people. Anyway, still, he assumed that the next step would be an investigation. Standard practice in the airline industry after every accident. You get an independent team in, you investigate, you learn. When he asked the head of the intensive care unit about this, the doctor shook his head. That's not how we do things in this healthcare service. What? Not unless somebody complains or sues. Fucking hell. The doctor was privately sympathetic to Bromiley's question, however. Shortly after Elaine's death, he got in touch with Martin to say that he had asked a friend of his, Professor Michael Harmer, an anaesthetist, if he would be prepared to lead an investigation. Harmer had said yes. After Bromiley gained the hospital's consent, Harmer set to work interviewing everyone involved, from the consultants to the nursing team, and that's the report I just read out. In July that year, he submitted his report. As Bromiley read it, his mind went back to one of the last nights he had spent in the hospital during his wife's coma, and to something that the duty nurse had said to him. Quote, "It's terrible. I can't believe that happened. With hindsight, that was a hint." Harmer's minute-by-minute narrative of the operation revealed a different story from the one Bromiley had heard when he spoke with the ENT surgeon. The truth was that Elaine had died at the hands of highly accomplished, technically proficient doctors with 60 years of experience between them in a fine, well-equipped modern hospital because of a simple error. Naturally, we respect and admire doctors. We believe that healthcare is scientific. We think of hospitals as places of safety. For all these reasons, it comes as something of a shock to realise that errors still play such a significant role in whether we leave a hospital better or worse, alive or dead. The National Audit Office estimates that there may be 34,000 deaths annually as a result of patient safety incidences. When he was a medical director, Liam Donaldson warned that the chances of dying as a result of a clinical error in hospital are 33,000 times higher than dying in an air crash.
Oh.
Wow.
Well, that's certainly even a lot higher than driving a car.
Yeah. This isn't a problem to our healthcare system per se. In the United States, errors are estimated to be the third most common cause of death in healthcare, like I said in the Redondivort case, after cancer and heart disease. Globally, there is a 1 in 10 chance that owing to preventable mistakes or oversights, a patient will leave a hospital in a worse state than they entered it, which is terrifying. There are other industries where mistakes carry grave consequences, but the mistakes of doctors carry a particular moral charge because their job is to make us better, and we place infinite trust in the expectation that they will do so. When you think about it, it's extraordinary. We are prepared to give a virtual stranger permission to cut us open with a knife and rearrange our insides as we sleep.
Isn't it amazing? I think about this often.
Yeah. We're like,
when the anaesthetist is talking to the patient, they go, "Hey, I'm James and I'll be your anaesthetist today." And I'm like, this person is about to have like a fucking massive 4-hour plus long operation and you've just met. And I think about that all the time.
Yes.
They've just met me too.
Yeah.
I've just met them. And here I am going, you'll be fine.
Yeah.
We'll be with you the whole time, you know.
We'll watch over you.
Yeah, we put you to sleep, we'll wake you up. We do this all the time.
And we mean what we say. We do it
Absolutely.
all the time. And 90% of the time it's fine.
Oh, more than that.
Yeah. And people,
98% of the time it's fine.
Yeah.
There's no emergency.
And because of this, people get complacent. They just do. Perhaps because of the almost superstitious faith we need to place in surgeons, we hate to think of them as fallible, to think that they perform worse when they are tired, or that some are much better at the job than others, or that hands can slip because of nerves, or that bad decisions can get taken because of overconfidence or stress or poor communication. But all of these things happen because doctors and nurses are human. So, what went down? Within 2 minutes of Elaine Bromiley's operation beginning, the anaesthetic consultant realised that the patient's airway had collapsed, hindering her supply of oxygen. After repeatedly trying and failing to ventilate the airway, he issued a call for help. An ENT surgeon answered it, and as did another senior anaesthetist, as we said. The 3 consultants struggled to get a tube down Elaine's throat, but encountered a mysterious blockage, so they tried again. Can't ventilate, can't intubate. Is a recognised emergency in anaesthetic practice, for which there are published guidelines. The first instruction in one version of the guidelines is, do not waste time trying to intubate when the priority is oxygenation.
Try other things.
Deprived of oxygen, our brain soon finds it hard to function. Our hearts struggle to beat. 10 minutes is about the longest we can suffer such a shortage before irreversible damage is done. But I think new information is that it's really only 4 minutes. The recommended solution is to carry out a form of tracheotomy, puncturing the windpipe to allow air in. Do not waste time trying to intubate. 20 minutes after Elaine's airway collapsed, the doctors were still trying to get a tube down her throat. The monitors indicated that her brain was starved of oxygen and her heart had slowed. Her face was blue. Her arms periodically shot up to her face, a sign that the brain tissue is being irritated. Yet the doctors ploughed on. If the severity of Elaine's condition in those crucial minutes wasn't registered by the doctors, it was noticed by others in the room. The nurses saw Elaine's erratic breathing, the blueness of her face, the swings in her blood pressure, the lowness of her oxygen levels and the convulsions of her body. They later said that they had been surprised when the doctors didn't attempt to gain access to the trachea, but felt unable to broach the subject, not directly anyway. One nurse located a tracheotomy set and presented it to the doctors, who didn't even acknowledge her. Another nurse phoned the intensive care unit and told them to prepare a bed immediately. When she informed the doctors of her action, they looked at her. She said later, as if she was overreacting. Regarding this, you may be incredulous and angry that the doctors could have been so stupid or careless, but when the person closest to this event, Martin Bromiley, read Harmer's report, he responded very differently. His main sensation wasn't shock or fury, it was recognition. Going back to the flight story, it's a miracle that only 10 people were killed after Flight 173 crashed into an area of woodland in suburban Portland. But the crash didn't have to happen at all. Had the captain attempted to land, the plane would have touched down safely. The subsequent investigation found that the landing gear had been down the whole time. Oh my God.
Here we go.
Fucking wow.
Amazing.
But the captain and officers of flight...
So something I would do.
But the captain and officers of Flight 173 became so engrossed in one puzzle that they became blind to the more urgent problem, fuel shortage. This is called fixation error. In a crisis, the brain's perceptual field narrows and shortens. We become seized by a tremendous compulsion to fix on the problem we think we can solve, and quickly lose awareness of almost everything else. It's an affliction to which even the most skilled and experienced professionals are prone. Imagine a stalled car stuck on a level crossing as a train bears down upon it. Panic rising, the driver starts and restores the engine rather than getting out of the car and running. Right? Just want to get the car out of the way. The 3 doctors bent over Elaine Bromiley's throat were intent on finding a way to intubate, just as the 3 pilots in the cockpit of United 173 were determined to establish the status of the landing gear. In neither case did these seasoned professionals look up and register the oncoming train. In the case of Elaine, her oxygen levels, and in the case of 173, the fuel levels. When people are fixating, their perception of time becomes highly erratic. Minutes stretch and elongate. One of the most striking aspects of the transcript of United 173's last minutes is the way the captain seems to be under the impression that he has plenty of time, right up until the moment the engines cut out. It's not that he didn't have the correct information, it's that his brain was running to a different clock. Similarly, it's not that the doctors weren't aware that Elaine Bromiley's oxygen supply was a problem, it's that their sense of how long she had been without it was distorted. When Harmer interviewed them, the anaesthetic consultant confessed that he had no idea how much time had passed. Imagine for a moment being one of those doctors. You have a patient who has stopped breathing, the clock is ticking, the standard procedure isn't working, but you have employed it dozens of times before and you know it works. Each of the senior colleagues around you is experiencing the same difficulty, which reassures you. You cling to the belief that between the 3 of you, you will solve the problem.
Yeah.
If it is solvable at all, you vaguely register nurses coming in and out of the room and saying things, but you don't really hear what they say. Perhaps it occurs to you to step back from the patient and demand a rethink, but you don't want your peers to see you as panicky or naive. So you focus on the thing that you can control, the procedure. You repeat it over and over, hoping for a different result. It is madness, but it is comprehensible madness. In the months after Elaine's death, as Bromiley tried to rebuild his family life, he couldn't stop wondering about the difference between the way people in healthcare treated accidents and the way his industry dealt with them. So he would phone people in and out of the National Health Service and ask them about it. He discovered that many others, an anaesthetist in Scotland, a medical researcher in London, had been wondering the same thing. Eventually, he accumulated a long list of like-minded people, none of whom was talking to any of the others. So he booked a room in a hotel, called a meeting and invited them all, along with experts from other industries and academics, including James Reason, who invented the Swiss cheese model. Everyone agreed that when it came to safety, healthcare was hanging out in the dark ages. Hospitals more or less pretended that mistakes didn't happen, failed to learn from them, and as a result repeated them. If we don't like to think that doctors make mistakes, doctors like to think about it even less. One of the biggest problems identified was the unwritten but entrenched hierarchy of hospitals. Martin, who has worked with experts from various safety-critical industries, including the military, said that the hospital is by far the most hierarchical place he has come across, and I would agree. At the top of the tree are the consultant surgeons, the rock stars at the hospital corridors, highly driven, competitive, mostly male, and not the kind who enjoy confessing to uncertainty. Then come the anaesthetists, often quieter of disposition and warier of risk. Further down are the nurses, valued for their hard work but not for their brains.
As if we don't have any.
A key principle of human factor is that it is the unspoken rule of who can say what and when that often lead to crucial things going unsaid. Hierarchy. It's dangerous. The most painful part of the transcript transcript of Flight 173's final hour is the flight engineer's interjections. You can sense his concern about the fuel situation and his hesitancy about expressing it. Perhaps he's assuming the captain and his officers know the urgency of their predicament. Perhaps he's worried about being seen to speak out of turn. Whatever it is, he doesn't say what he feels. This is an emergency. We need to get this plane on the ground. On the ground now.
On the ground.
But it's true, isn't it? Similarly, the nurses who could see the urgency of Elaine Bromiley's condition didn't feel able to tell the doctors that they were on the verge of committing a grave error. So they made tentative suggestions that were easy to ignore. They didn't go, stop what you're doing.
Yeah.
We need to do something else. We need to do a front of neck access now.
Because we can't sort of...
We can't do that because of hierarchy. It's as simple as that. They don't listen to us. It is what it is. John Pickles, an ENT surgeon and former medical director of Luton and Dunstable Hospital NHS Foundation Trust, said that usually when an operation is carried out on the wrong part of the body, a class of error known as wrong site surgery, there is at least one person in the room who knows or suspects a mistake is being made.
Oh my God.
Yep. He recalled the case. I believe it though.
I know. I'm just remembering all the times that I went,
wrong leg.
this is wrong. Wrong
And then they go,
kidney.
and then
the
they go,
consultant comes in and, oh my God, I just remember this one time the reg was about to start like literally stenting this person's ureter. And the consultant came in and he's like, so what side are we operating on today? And the registrar goes, I don't know. And he's about to put a stent in the ureter. And the consultant, I love this urologist. He was this Israeli guy and he was like, he acted like a doctor, but he protected nurses.
Yeah, right.
Anyway, he was lovely. He
was a good leader.
So much.
Yeah.
But he comes in and he asked him and he goes, no, I don't know which side. What the fuck?
What?
And
Did you not time out and say?
Yeah, right. And I'm scrubbing at the time for this. And he says, take your hands off the patient.
Period.
Take your hands off the patient right now to the registrar.
Oh, wow.
Put the instrument down.
Yeah, wow.
Get out of theatre right now.
Wow.
He was not allowed to come back because he's about to operate on a patient that he hasn't even looked at the fucking consent form and seen what he's about to do. And he's just about to go and stent a ureter.
And he's clearly in the room.
Which one,
when
though?
They're timing out. We are supposed to do a team out.
He was not in there for timeout. This is a public hospital because it's a public hospital and they just feel like they can do whatever they want.
So we can't do a timeout without the surgeon who is operating in the room for that fucking reason.
But they will. Or they'll forget about the timeout altogether.
Or they'll be in there, but they won't be listening. They'll be chatting on their phones. Yeah. They'll be chatting with each other.
Yeah,
and
they're writing
just
an email.
Fucked. And that's the reality, guys. You have to be assertive as a nurse to work in the operating room to keep your patient safe. And you have to come across as a bitch sometimes to these fucking surgeons because they don't value us as team members.
There's one thing that one surgeon said to me once, Kate Drummond, and I'll never forget it. It's simply 2 words. Question everything.
Yeah, absolutely.
Question everything. And she said that to me one time, looking me directly in the eyes, because I said something about like, I feel wrong questioning things. And she's like, she just looked at me and she said, question everything.
Period.
Always question everything. Everything everyone does that you do, question it.
Great advice. Shout out to Kate Drummond.
Yeah. She's
Again.
just standing there
such
operating, looks up and goes, question everything.
Yeah, she's so cool.
I will, doctor. Thank you. I will.
By far the coolest surgeon.
Also, one other thing.
What?
I just wrote some little notes that have questions.
Go for it.
The sleep deprivation, yeah. There have been so many studies that have been done on sleep deprivation, and it's been proven that once you get to like 24 hours plus of no sleep, your cognitive function starts to significantly decline to the point where if you go like 36 plus hours without sleep, humans will start to hallucinate and you actually become completely...
unable to function, yeah.
Yeah, you get confused. People lose track of the time, what time of day it is, how long it's been...
Their situational
where they are.
awareness.
Yeah.
Yeah.
And also I have a question. You know that fancy ManuJet thing we love to use for ENT?
Yep.
Did they have anything like that?
Nothing is mentioned.
Okay.
That would have been helpful. Just put a catheter down there and fucking jet ventilate.
Literally,
the patient.
that's what that's for, and it's an amazing lifesaver.
Yeah. He recalled the case of a patient in South Wales who had the wrong kidney removed. A female medical student had pointed out the impending error, but the 2 male surgeons ignored her and carried on. The patient, who was 70 years old, was left with 1 diseased kidney and died 6 weeks later. In other cases, nobody spoke up at all. The pioneers of crew resource management knew that merely warning pilots about fixation error was not sufficient enough. It is too powerful an instinct to be repressed entirely, even when you know about it. The answer lay with the crew. The entire aircraft crew needed to act as a collective intelligence, vigilant for problems and responsible for solutions. It's the people at the edge of the room standing back from the situation who can often see it best, Martin said. He's a brilliant man. They're watching. They're watching what people do, and they're thinking about, they're not honed in on one problem, they're thinking about the situation.
Right, you observe every single person when you walk into something like that.
It's like watching a TV show and go, I would have done this differently. Like,
what are they
it's
doing
like nurses
there?
watching Grey's Anatomy and going, what the fuck? Like, that is what it is.
Yeah.
He recalled the case of British Midland Flight 92, which had just taken off for its flight from London to Belfast on 8th of January 1989, when the pilots discovered one of the engines was on fire. Following procedure, they shut it down. Over the PA, the captain explained that because of a problem with the right engine, he was making an emergency landing. The cabin staff, who, like the passengers but unlike the cockpit crew, could see smoke and flames coming from the left engine, didn't pass this information on to the cockpit. After the pilots shut down the only functioning engine, British Midland 92 crashed into the embankment of the M1 motorway near Kegworth in Lancashire. 47 of the 126 people on board died. 74 sustained serious injuries. The airline industry pinpointed a major block to communication among the members of the cockpit crew. The captain. The rank of captain retained the aura of imperial command. The pioneers of CRM realised that, in the age of mass air travel, charismatic heroism was precisely the wrong stuff. The industry needed team players. The captain's aura was a force field, stopping other crew members from speaking their minds at critical moments. It wasn't just the instrument panel that had to change, it was the culture of the cockpit. Long before they started doing more good than harm, surgeons were revered as men of genius. In the 18th and 19th centuries, surgical superstars performed operations in packed amphitheatres before hushed, admiring audiences. A great surgeon was a performer for the hands of God. His nurses and assistants were present merely to follow the great man's commands, much as the planets in the orbit revolve the sun. The advent of medical science gave this myth a ground in reality. At least we can be confident that the doctors today make people better most of the time. But it reinforced a mystique that most doctors, and especially surgeons who, of course, still perform in operating theatres, hard to question by either patients or staff. Better safety involves bringing doctors off their pedestal, or rather inviting them to step down from it.
There was one time I was working with a reg in a public hospital, and he was trying to intubate the patient, and he tried for a 3rd time, and I was a grad at the time, and I
You don't feel qualified to speak up, do you?
And basically the patient stats were in the 60s, and I'm like, can I push the red buzzer, because then we can get the consultant on. And he actually did come in, and I was like, I wanted to press the buzzer, I said at some point, and he was like, it's actually probably good that you didn't, because then everyone comes in and then shit happens and gets messy, right? But everyone told me afterwards I absolutely should have. And I don't even...
Yep.
And the only reason I listened to this fucking little lanky, weeny little registrar guy is because he's a doctor and I wasn't. And I was just a grad, and I was like 6 months in. I don't fucking know anything. But I do know that you're trying for a 3rd time to get the tube in, and you're just a 1st-year anaesthetic reg, and the patient's desatted into 60. I know that much is wrong. At what point would he have let it get to?
Yeah.
You know, is what I wonder.
So did you press it? Like how?
No,
you just
someone
called,
ran out to get...
Yeah, it's like... Okay,
they knew where he was.
He's not letting us press the buzzer. We will leave and find someone.
Isn't that fucking ridiculous? We have to like go behind this doctor's back to go and get help so a patient doesn't die because he's too fucking proud as a registrar, thinks that he knows his shit and he's going to get it in. Newsflash, he didn't.
Yeah. Yep.
Stop thinking that you are more capable than you are just because you're a doctor.
That's it.
Doesn't mean shit.
You need to admit your limits. You have to be
and
able
admit
to
when you're wrong.
Say to people,
and don't know what you're doing.
Yeah, not necessarily wrong, but just like, okay, this isn't working. I need help.
Yeah,
but it is hard to admit it. because the culture makes it that way. Modern medicine is more reliant than ever on teamwork. As operations become more complex, more people and procedures are involved. Operating rooms swarm with people. Various specialists pronounce judgment or perform procedures and then leave. Surgical teams are often comprised of individuals who know each other only vaguely, if at all.
Yeah.
It is a simple but unavoidable truth that the more people are involved in something and the less well they know each other, the more likely it is that someone will make an error.
When you know your anaesthetist and they know you've worked together for a long time, or you work together every day doing the same type of list and cases, things just flow.
Totally. The most significant human factors prevention tactic in healthcare in recent years is the checklist. Borrowed from the airline industry, the checklist is a standardised list of procedures to follow for every operation and for every circumstance. Checklists compensate for the inbuilt tendency of human beings under stress to forget or ignore what is important, including the most basic things. The first item on the aviation checklist is fly the aeroplane. Crazy. They also empower the people at the edges of the room. Before the operation and at key moments during it, the whole team goes through each point in turn, including emergencies, which gives a cue to more reserved members of the team to speak up. Checklists are more effective in an atmosphere of informality and openness. It has been shown that simply using the first name of the other team members improves communication, and that giving people a chance to say something at the beginning of a case makes them more likely to speak up during the operation itself. That's why team meetings at the start of every case or every list is so helpful.
And it's also really nice when you do get a surgeon that actually looks around at everyone in the room and goes,
wants to know your name.
Anything
to add?
Or does anyone have any concerns?
Yes. Naturally, the spirit of openness entails a diminishment of the surgeon's power or a dispersal of that power around the team. Some doctors don't mind this. In fact, they welcome it because they realise that their team can save them from career-ruining mistakes.
Yes.
Others, however, are more resistant, particularly those who treasure their independence.
Have Mavericks. You ever saved a doctor from...
Yeah. Mavericks don't do checklists. Even those who see themselves as evolved team players may overestimate their openness. A psychologist at Johns Hopkins University in the US has conducted global surveys of operating room staff. He found that while 64% of surgeons rated their operations as having high levels of teamwork, only 28% of nurses agreed. Speaks volumes.
That is so interesting.
The lessons of human factors go far beyond the status of surgeons. From his earliest conversations with insiders, Martin Bromiley realised that the NHS needed to undergo a profound cultural change if it was to reach the level of aviation industry in terms of safety. Hospitals gave little or no thought to how their teams functioned. Doctors underestimated the effects of tiredness on their own performance. Medical schools taught doctors that technical excellence trumped everything else and spent little or no time teaching communication or team management skills. That is evident. They're shit communicators. Specialists saw their job as fixing parts of the body rather than helping a person. There was little or no data on which hospitals and doctors were making mistakes. Safety risks were routinely misperceived. The can't ventilate, can't intubate emergency happens about 1 in every 20,000 times, which anaesthetists consider to be a remote possibility. Yet, as Martin said in aviation, when we find out there's a 1 in a million chance of an engine failing, we worry. To me, 1 in 20,000 means a regular occurrence. As the psychologist James Reason showed, mistakes arise out of coincidence. A consultant paediatrician in Birmingham told me that when mistakes happen, it's almost never one person's fault. It's usually a whole series of things. Martin Bromiley asked hospital boards to consider their procurement of marker pens used to mark the part of the body about to be operated on. Best practice is for the surgeon to make the mark and to sign it with his initials. Martin said, I tell them, I understand your need to cut budgets, but do you realise that because you didn't buy those marker pens, you've just trebled your likelihood of having a wrong site surgery case? Yeah. There is now greater awareness of the complexity of safety than ever. The body that Martin Bromiley founded, the Clinical Human Factors Group, has no official status within the NHS, but its influence has been felt right across the institution and internationally as well. In the case of Elaine Bromiley, there was too much hierarchy and too little. On the one hand, the nurses didn't assert themselves. On the other hand, nobody was taking ultimate responsibility for the patient's safety, like there was no leader. As John Pickles remarks, You had 3 very senior people in the room and no one in charge. Hierarchy, in the sense of clear leadership, is a good thing, as long as the leaders are confident enough to confess uncertainty. A common problem is young doctors being reluctant to say they don't know what the answer is because they are so eager to project competence, and this goes for nursing as well. A member of her team said, well, when you're stuck, ask everyone in the team for their view. One of them probably has the answer, but until you speak up, they'll assume you have it too. These sorts of lessons weren't being given 10 years ago. The Great Ormond Street Children's Hospital in London is at the forefront of the new thinking about patient safety and is absorbing lessons from other industries. In collaboration with the human factors, this hospital studied the process of pit stop changes in Formula One, learning that importance of every individual on the team being allocated a precisely defined task. Once they implemented this, the level of mistakes fell. Martin Bromiley has rebuilt his life, happily remarried. He is a stepdad to his second wife's 2 children, as well as still dad to Victoria and Adam. He is not haunted by the tragedy of Elaine's death, but driven by it. Between flying commitments, he talks to doctors, nurses, researchers, and NHS boards, connecting the like-minded, telling his story to those, whether managers or medical students, who most need to hear it. Improving the safety of patients in healthcare doesn't necessarily require spending on expensive new technologies or complex structural reorganisation. It requires forethought, empathy, humility, and willingness to learn from mistakes, which, after all, is a duty to those who have suffered from them. Martin Bromiley insisted that the Harmer report be made public, as happens with an air accident report, and he chose for it a quote borrowed from aviation, so that others may learn and even more may live. All of the medical staff involved in Elaine's operation are back at work. That, says Martin, is exactly what he wanted, because they will be better clinicians for their experience and advocates for the cause. He's such an amazing man. So brilliant.
This makes me sort of think back to that time where I had that patient in recovery who ended up having the bilateral PEs. I wonder if I was a grad or something and I went to the anaesthetist and I said, something just doesn't feel right, would he have been able to sense that and treated me differently? Like, that's such a stupid sentence to say almost to a doctor, right? Something's not right. But I'm so glad that he didn't look at me like an idiot.
But for that one circumstance, how many more were you ignored by doctors, you know?
That's
it's
very
a fucking
true.
cultural problem that needs to change. We need to keep talking about it, which is why I've done an episode on it today. And people say to me that hierarchy is good, is normal. It's in the military, it's in various places, and it's important to have a leader. And I agree with the leader thing, but you need to have a leader who is willing to lay down his or her ego, and listen to your team in order to keep the goal, which is to keep the patient safe and get them through their operation. Like, there's clear evidence to show through multiple patient deaths that errors in communication result in catastrophe. And we need to be able to open the communication up to the team. There's a reason we have a team, because of human error.
And sometimes you get doctors, I swear they think they've already told you something, but really they've just said it in their brain.
Their head, yeah. Yeah. So I hope you found that informative. I really worked hard on that one. I wanted to emphasise the fact that it's about teamwork and not about ego. And checklists are important. And it's also really important to introduce yourself at the start of the list. There's so many fucking surgeons who bitch about it and they're like, doesn't make a difference, I'll forget it in 2 seconds. And it's like, yeah, you might, but I won't. Like,
but then sometimes you come in and don't introduce yourself, and then they come at you later and they're like, sorry, I didn't catch your name. What was your name?
Important.
You didn't introduce yourself. And I'm like, because you were operating scrubbed at the time.
Yeah, but if you introduce yourself and do a team meeting at the start, you build that rapport and you open up the lines of communication. You embolden people to be able to speak up in the procedure. That is the point. So stay safe, guys, in your practice. I hope this was informative. Follow our Instagram, email us, all the things. Olivia has to shit, so we're going.
Bye.
Any questions that you have, please put in the comment section. I'm now alone. Olivia's running away. Make sure that you comment on Spotify and email us at nurseratchetpodcast@gmail.com, and always speak up for your patient at the end of the day. Okay. Love y'all. See you in the next one.